evening. Let me take you for a SPiM. Thank you, Manoj, and thank you, Unni, for putting up such a wonderful program and making me a part of it and giving me an opportunity to learn from all of you. So I'm going to talk about the importance of SPiM as a prognostic tool in DME. We all know how OCTA works, and the decorrelation signal that gives indicates the blood flow. And we are also taught that when there is a no vascular component and we have a signal, decorrelation signal, it is to be considered as an artifact. In 2017, Kashani et al. Presented a non-vascular decorrelation signal from cysts in DME cases and in BRVO cases. So they labeled this as SPiM, or suspended scattering particles in motion. And they described them as oval or circular regions of variable reflectivity with the decorrelation signal. Most likely, they represented Brownian motion, which was a very slow kind of movement, not like the typical rheological flow of particular matter which was contained in the intraretinal fluid. They also found that it was usually associated with hyperreflective material bordering the fluid. However, they could not elaborate on the long-term clinical significance of this. This SPiM correlates with OCT also. So in case you don't have an OCTA, you can still see hyperreflectivity within the cyst, and this correlates very well with variable gray levels also. The contents could be corpuscular, protein, hyaline material, or lipid-laden macrophages. And this, stationary speckle signal from very high reflectance material could not be excluded. So these cystoids can be hyporeflective. They may have reflectivity and not have decorrelation signal, then they are called as corpusculate. Or they could be SPiM when there is hyperreflectivity and decorrelation signal. So this is an example of corpusculate cystoid. You can see the hyperreflectivity in the cyst, but you don't see any decorrelation signal or flow signal on the OCTA B scan. This is another patient. You have almost 10 months gap. The macular edema increased, and the OCTA here shows a hyperreflective cyst with decorrelation signal. This is a SPiM. The fellow eye, however, also showed some decorrelation signal, which was correlating to the hyperreflectivity at the subfoveal region and also the next to the hard exudates and the parafoveal region. So we'll come to this later. So the incidence, they found in treatment naive as well as treated eyes, around 2/3 of these eyes would have SPiM, more common in older patients. And when there was history of previous intraocular therapy, some authors found that there was a higher incidence of SPiM. This SPiM was also more commonly seen in the deep capillary plexus. So etiopathogenesis is not clear, but they say that the sources could be because of the Muller cell dysfunction or leakage from the microaneurysms. The content most likely is lipid and proteinaceous material, as has been elaborated by a phantom model. The degree of the blood retinal barrier breakdown and the vascular permeability may reflect on the type and amount of exudate that enters this intraretinal fluid. So what are the clinical implications of this? The greater particle flow may reflect greater blood retinal barrier breakdown, and the treatment response may be reflected on this. Eyes with SPiM are also associated with higher optical density ratio and increased hyperreflective foci, and lesser reduction of this intraretinal cyst size is seen after treatment. So this paper showed that there is more chances of no response or higher chances of, less chances of complete response and higher chances of no response when SPiM was associated. And they also found that this was more commonly seen in outer nuclear layer. So this is an example from the same paper where they showed the hyperreflectivity and the decorrelation signal as seen on the on-fast OCTA reduced. The intraretinal fluid spaces which are hyperreflective disappeared completely. However, there was enlargement of the cyst which contained SPiM. And on the right picture, you can see the cyst reduced in size, but the decorrelation signal also reduced in size, but did not completely disappear, unlike the hyperreflective cyst. SPiM was also like SPiM in the nerve fiber layer was more associated with a good therapeutic response as compared to the outer nuclear layer SPiMs. So the prognostic implications, SPiM confined to outer retina responded better to dexamethasone. The previous paper was with anti-VEGF. So when associated with SPiM, steroid response was better, but there are no clear-cut definitions or clear-cut evidence that steroids have a better response as compared to anti-VEGF in head-to-head trials. This is an example of a patient who had waxing and waning of macular edema treated with IVTA and focal laser. And at the last visit, when we saw hyperreflectivity within the parafoveal cyst, we did a OCTA and found that there was a SPiM decorrelation signal. All OCTA machines algorithms are different, and they cannot be compared head-to-head. Plex Elite with OMAG algorithm showed that there are higher SPiM detection, and manual segmentation lines were easy to modify, and there was more internal reflectivity on Plex Elite platform as compared to AngioView. I have no financial interest. There could be also non-vascular decorrelation detected on OCTA. A particle with high reflectivity can cause OCTA image artifact, as seen in this picture where they could see a PED line on the OCTA angio. A large lesion like the intraretinal cyst induced multiple dynamic backscattering and also showed a OCTA signal. So reflectance decorrelation foci, as seen on this, corresponding to the high reflective spots or hyperreflective foci, and also projection artifacts. So these has to be excluded before you diagnose SPiM. So to conclude, there are no systemic correlation with this metabolic status. SPiM may be useful biomarker when considered with associated features like hyperreflective foci or perfusion density. OCTA devices are not interchangeable for analyzing reflectivity. Response to therapy with anti-VEGF and steroid is variable, and there is no clear-cut evidence of the superiority of one over the other. And morphofunctional correlation associated with SPiM needs better tools than ETRS visual acuity. Thank you so much for your kind attention.
Yeah, thank you very much, Dr. Singh. So my question to the panel would be, in your practice for DME management, when would you actually advise OCTA for the patient to detect SPiM?
This was a very good presentation, thank you. So the SPiM is a very recent, I would say, parameter that was evaluated. And I think it is an interesting parameter, but it's difficult to detect in everyday clinical practice, especially on OCTA. You need to look at the deep capillary plexus, which in DME is not always easy to evaluate. So as you pointed out, there can be a lot of projection artifacts, and I think we still cannot rely just on looking at the SPiM. It's something that we need to study more and understand more.
To take care of that point, actually, most of the cysts or SPiMs that have been studied, they've taken the parafoveal cysts only. So there the segmentation may not have much impact. So that is their justification in the discussion part.
In the, okay, yeah, but still it's yeah, the deep capillary plexus, so it's not easy. Yeah.
So in practice,
Jay, I'll ask you the reverse question. Why do I need to look for it? Why do I need to look for it? You said, when would you do an OCT angio to look for SPiM? Why do I need to look for it?
I think maybe Dr. Singh can take that question.
I'm asking the moderator.
Yeah.
So I think it has been shown to be correlating with the treatment response also.
Makes no difference. Both work equally well.
Yeah, but the steroids are supposedly work better for patients who have SPiM.
But that's not what Jatinder said.
If you look at the pathophysiology, there is more amount of lipid exudation that is associated in patients with SPiM.
So, yeah, so you know, that's not what Jatinder said. He said that both work equally well. Now, if both work equally well, how does it matter to me which I use? Either way, I'm not going to change my management. So, yeah.
So this is probably my lack of understanding, having not read the papers. So with most of these devices, there's a lower limit of detection to stop you seeing noise, which probably would include Brownian motion noise in most cases. And for that reason, we often don't detect slow flow in microaneurysms or polyps. But we're seeing these. I still not quite, is just a noise effect? Just by some chance of the sequential OCTs cutting something that happens to move slightly? So, maybe I didn't quite follow it.
So the original paper actually said that it's because of the Brownian motion within the cystoid cavity because of the lipid molecules moving slowly.
But there's Brownian motion, but that's what the lower limit of detection would cut off. So the original Heidelberg retina flow meter probably had a detection of Brownian motion, which is why it detected flow even when there was no flow in kind of tube models. But I think the lower limit of cutoff here probably should get rid of that.
No. So the OCTA signal would be picked up if there is, the flow is 0.3 to 4 meter per second. The velocity of the particles are of that range. So this is beyond more than 0.3. So that is what the authors have.
So okay. So they just think there are particles that are moving at that speed in these tiny areas at Brownian motion.
So what was actually intriguing to me is appearance which Anand has published as fried egg. The particles would move to one end and they are still moving in a Brownian motion is something which was very confusing. Doesn't just appeal, that concept does not appeal. I actually agree with what...
Yeah, it doesn't make sense, but that's because maybe I just don't know enough biophysics to really understand.
I think it would need to... I think it would need to have a certain size to allow a Brownian motion. If it's too small, there wouldn't be any Brownian motion. There has to, because Brownian is random.
It's just random movement of particles in fluid.
So if it's too small a cyst, it won't happen. And it has to be plasmoid enough, because otherwise, again, it doesn't have the weight, the density to move as a particle.
I presume the authors of these papers talked to the biophysics guys and have
I must say, I read the papers but did not understand it.
Oh, good. So, Dr. Stewart,
I'm going to add my lack of understanding to Adnan's here. So, to me, this is an interesting finding. It may have prognostic significance, but it doesn't alter therapeutics. That's kind of the way I summarize this.
Thanks a lot, Dr. Stewart. So, thank you, Dr. Singh. So, next